Welcome, everyone. This week we'll be talking about puerperium physiology, also known as the postpartum period. So to provide a brief overview, we'll be describing the physiologic changes during the puerperium for the following systems. So we'll start with the uterus and the uterine body, and then talk more specifically about the endometrium and that placental site, including uterine vessels. And then we'll go on to talk about the cervix and the lower uterine segment, the vagina and perineum, and then we'll talk about the peritoneum and the abdominal wall, endocrine system, cardiovascular system, and finally the urinary tract. So simply put, this is the time after childbirth where a person who was pregnant is reaching their new non-pregnant state. So it may not be similar to their pre-pregnant state, especially if this is their first child. So it's about reaching that new level of normal for them. And it typically lasts about 6 to 12 weeks. That said, we really do want to treat that full year after giving birth as being a postpartum year for full recovery. So keep that in the back of your mind as well, even as the technical definition for puerperium is 6 to 12 weeks. There were a lot of anatomic and physiologic changes in pregnancy, so this is about how they resolve after childbirth. And it's also a time to really adjust to parenthood while the body is readjusting to a non-pregnant state. Certainly having a holistic approach to this that includes social, psychological, spiritual aspects in addition to those physical aspects for a full transition. So the uterine corpus involution is basically the uterus shrinking back down to size to be in its non-pregnant state. So you'll have strong, sustained contractions for about 1 to 12 hours, and then there's a slight relaxation, but by that point the blood vessels have clotted, so we shouldn't have continued extensive bleeding from that placental site. That clotting means that we shouldn't be at a high risk for extensive bleeding. So the rate of involution is about 1 finger breadth a day. So it starts at the umbilicus or umbilicus, and then each day it'd be about 1 finger breadth lower. And then by 10 to 12 days, it really shouldn't be palpable anymore when you're palpating your abdomen. And by about 2 weeks, it's fully in her pelvis. And it should be a normal size by 4 to 6 weeks. So it really is important to have a good sense of what normal would be. So if a woman calls you and she's 2 weeks postpartum and it sounds like her bleeding is heavier than you're expecting, you bring her in and you palpate for her fundus and you're finding it halfway between her umbilicus and her pubic bone, that's not a fast enough rate of involution, and that's probably tied to the reason why she is bleeding excessively. So having a strong sense of what you're expecting to see for normal involution will help you identify if you're not on the right track. So for that mom, maybe a piece of the placenta is still stuck up inside and her uterus is having a hard time fully clamping down. Or maybe she's too active and that extra activity is making it hard for her uterus to stay constricted well. So know what normal is and then do your assessment from there to be able to line it up and see if it's where it's expected. So by 4 to 6 weeks, we are back to normal size. How does the uterus get from being so big it can hold a baby to back down to just fitting in the pelvis? So there's 2 primary ways that happens. One is by autolysis of extra actin and myosin. And then the other way is that it occurs primarily by reduction in cell size. So if you remember in pregnancy, that uterine growth takes place by both hypertrophy and hyperplasia. So we have more uterine muscle cells and those cells are bigger. However, in postpartum, rather than reducing the number of cells, we're really just reducing the size of cells. And because of that, if this is somebody's first pregnancy, their uterus is going to end up in its non-pregnant state a little bit larger than it was pre-pregnancy. Now, while the uterus may be back to normal size by 4 to 6 weeks, it generally does take longer for it to become as firm as a non-pregnant uterus. So, for example, this has implications for IUD placements. It's generally easier to put IUDs in postpartum because the uterus is a bit softer, that cervix is a little bit more open still. And so it goes in pretty easily. But also because it is less firm, it's more likely to fall out. So you might put it in and a week later she comes back and it fell out. So that's an expulsion. And then that uterine wall is a bit thinner and softer, so it would be more easy for that IUD to travel through the uterine wall and into her abdomen. So that would be a perforation. So it's not a contraindication for putting in IUDs postpartum. They can be a great form of birth control in that time period, but just to know that the rates of expulsion and perforation are a little bit higher because that uterus isn't as firm. So now I have a few images here from your COAD text. So that column on the left, that wide open circle, that's a blood vessel immediately postpartum, and then you have the myometrial cells all the way around it, and you can see when the uterus contracts that those myometrial cells are contracting, and that helps to occlude the blood vessel. And then you're seeing the same thing in B, that second column, where the blue line is your blood vessel, and the white fibers, those are your myometrial cells. So when they start to constrict, that squeezes and clamps off the blood vessels to slow bleeding. So especially those first 12 hours postpartum where you have that strong, sustained contraction, that helps to keep bleeding minimal. And then in the final picture, you see what a pregnant muscle fiber would look like. That's the myometrial cell on top. And then it's not that we're reducing the number of cells, we're just making them shorter. So it gets smaller and smaller and smaller. So you see the postpartum one is kind of on the right, the upper right, and then the bottom one is how it started prior to pregnancy. So now let's talk about the endometrium or inner lining of the uterus. What's going on there as the uterus is involuting? So there's a decrease in surface area, and that's what helps to shear the placenta off. So you had a baby filling up a lot of space in the uterus, and when the baby comes off, it's like the uterus has a buckling where it starts to shrink back down, and that's what causes the placenta to begin to shear off. So there's a decrease in surface, and then once the placenta is out, then you have even further room for that uterine endometrium to decrease in surface area as it's buckling down. Hemostasis is primarily achieved by smooth muscle contraction and compression of the blood vessels by uterine muscle. So that's what we saw in those last images. Those myometrial cells are running through and in and around those blood vessels. So when they contract, that helps to cut off the blood vessels to slow bleeding. Physiologically, there's an immediate inflammatory reaction for about 10 days that helps to provide an antibacterial barrier. So birth itself really opens up the uterus to the risk for infection more than like a non-pregnant or even pregnant state, in that usually the cervix is tightly closed and there's mucus in there to block it, keeping the uterus as a pretty sterile environment. However, during birth, the cervix opens up to 10 centimeters, and once you factor in potential medical interventions such as vaginal exam checks or maybe even a manual removal of the placenta, the risk for infection would be increased for her postpartum. So that immediate inflammatory reaction is a helpful buffer and barrier for her in that immediate postpartum period. And then glands begin to reappear by 7 days. So that's just part of what makes up the endometrial lining in preparation for her to have future menstrual periods. So the restoration of the endometrium in general takes about 16 days. And then that placental site takes longer, generally around 6 weeks before it's healed. And while it is essentially healed, I think it's just worth noting that that placental site does bear just a little bit of scarring. There's a little bit of an increased risk with future pregnancies for an accreta at that site, just because of the scarring. So it's essentially restored by 6 weeks, but never fully the same in the area where that placental site was before. So following just one pregnancy, there'd just be the smallest increased risk with subsequent pregnancies, whereas if a woman has had a lot of babies, then that's, multiple scar sites across her uterus, and that risk would increase a little bit more with each pregnancy, making it easier for subsequent pregnancies to embed deeper during implantation. So postpartum bleeding moves through 3 phases. So lochia rubra is that bright red blood, and then that moves into lochia serosa, and then finally lochia alba. So lochia rubra is going to be that bright red, fresh blood, reddish to reddish brown, that we see in those first 3 to 4 days. And it's primarily blood, but it's also residual fetal cells as well as decidua. So we expect to see it kind of brighter red in those first 3 to 4 days, like a really heavy period, maybe some clots in there too, nothing too big. I say you can have, one big isolated clot once you're out of my care, maybe a few little ones, but I really don't want to see any more than that. And then After that point, it would transfer over to being more of a lochia serosa, where it's more pink. However, right around day 7 to 14, I would expect it to look a little bit more like lochia rubra again, as there's a scar that forms over that placental site, or an eschar, and it's going to slough off. So somewhere in that 7 to 14 day range, I'd expect to see kind of an increase in more of a red, fresh blood look to her bleeding. So if a patient is paging around day 10 saying, hey, my bleeding's picked up a little bit today, I'm guessing that's what this is it's that eschar sloughing off and we're just having some bright bleeding again. And I think it's worth preparing moms for this ahead of time so that they can anticipate that, somewhere in that 7 to 14 day periods, it'll pick up and then it'll slow back down again after a day or two. So then moving on to lochia serosa, it's still blood, so more pinky brown. And then it also has some wound exudate in there too from that placental site sloughing and some leukocytes and some decidua. Lochia serosa is somewhat mucopurulent, meaning it's a little bit malodorous. And that's especially true with sweat. So if women are just saying, I just feel like I don't smell very good down there, that's normal. That's not uncommon. And the difference we're looking for there is that it's not smelling like rotting meat. So if she says she went for a long walk and she came back and went to the bathroom and just felt like she smelled down there, I'd say, take a shower, put on a fresh pad, be in that for a little bit, and then go ahead and smell again. And it should mostly have been resolved by that alone. If it's still persisting and smelling pretty bad, then that would be worth looking into a little bit more. But for women to say in general it doesn't smell very good, expect it. So lochia serosa lasts around 5 to 9 days, though in 10 to 15% it can persist to 6 weeks. And then that's followed up by lochia alba, which is basically a yellow to white discharge where the blood components in her discharge aren't there anymore. And then in terms of the overall length of bleeding, the mean length there is around 21 days, ranging generally from anywhere from 10 to 42 days. So it starts out as a heavy period for the first 4 or 5 days or so, and then that'll transition over to lochia serosa, where it's kind of a lighter bleeding, and then that usually goes for a week or two, and then we're transitioning over to lochia alba, and that'll persist for another week or two or so. So when patients come in for their 6-week postpartum visits, I'm really expecting that their bleeding is going to be fully resolved by then. And some will say, yep, about a week ago, I'd say that's when it was all done. And some will say, oh gosh, my bleeding's basically been done since 2 weeks. So you'll see a variation there. But by 6 weeks, I'm expecting that we're basically all the way done. So moving along to the cervix, it begins reforming immediately after the birth. I think it's worth acknowledging that it went through a lot. The cervix goes through a really big transition. When you're in the middle of labor, it might feel like it's taking a long time for it to change and dilate and open and efface. But that's a lot of transition. And then immediately postpartum, it starts shrinking right back down again. And it may be edematous, it may be lacerated or have some bruising immediately after the delivery as well. In terms of dilation, it would typically still be able to admit about 3 fingers for up to a week postpartum. Even with all those changes, by 6 weeks postpartum, it's essentially all resolved unless there was some kind of significant cervical laceration or something. There's good healing in that area. Estrogen helps. And then that external os may be permanently changed. Generally speaking, you've got that little round opening pre-pregnancy, and then after somebody has given birth for the rest of their life, it'll be more like a slit and less like a round hole. And then just 2 things I wanted to note about the immediate postpartum period. If you've got a woman who's bleeding pretty heavily and it seems like her uterus is involuting and pretty firm, but she continues to bleed heavily, it may be worth putting in a speculum and seeing if she might have a cervical laceration. So specifically at 6 and 9 o'clock, that's where those 2 arteries are, and they can really be spurters. So that's worth having in the back of your head as a potential differential diagnosis. And then the second piece I wanted to note is that it really does start shrinking down immediately postpartum. So I've been at a few hemorrhages where I've needed to go in and get the placenta to do a manual removal. And especially if you've also been adding pit, that can also make it come down faster. And it's like she's already 3 to 4 centimeters and I'm needing to get my whole hand in there to find her placenta and help deliver it. So just be cognizant that that really does start coming down quickly. And in terms of how quickly you may need to intervene, that's worth keeping in the back of your mind if you're considering potentially needing to do a manual removal, is how long has it been since the birth? And the longer you wait, the more challenging it may be to be able to get your hand in. And then here we have a good example of a primiparous cervix on the left, or a nulliparous cervix, so somebody who hasn't given birth vaginally. And then on the right, we have a multiparous cervix. So at some point they have given birth, and that's why it looks like a slit. Okay, so ovarian function. What we're thinking about here is we're wondering, when is her period going to come back? So all of pregnancy, her ovaries have basically been little shriveled up raisins. They're not functioning beyond those first 10 weeks where they're helping with some progesterone until the placenta takes over. But otherwise, the placenta for all of pregnancy has been the source of all hormones, and the ovaries have just been small and quiet. So let's say a woman isn't breastfeeding. What are her ovaries doing in that case? So postpartum, prolactin begins to be released in order to initiate lactation, which we'll talk about next week. But if she's not breastfeeding, then prolactin falls to normal by around 3 weeks. And with prolactin falling, that's going to trigger estrogen to begin to rise by 2 weeks postpartum. So even the fact that we're seeing estrogen, that means we've got follicles that are being recruited, that are starting to release and synthesize estrogen. So without prolactin's presence as an inhibiting process, you'll start to have follicles again, and our menstrual cycle is starting right there from the get-go. People can ovulate as early as 27 days postpartum. So while that's the earliest, the mean time to ovulation is 70 to 75 days postpartum if you're not breastfeeding. So then that would translate to a mean return to menstruation in about 7 to 9 weeks postpartum. And by 12 weeks, the majority of women are menstruating again, so about 70%. And it's important to keep in mind that the first time they ovulate, they won't have had a period yet. So they'll ovulate, that'll trigger the corpus luteum that releases progesterone, and then as progesterone dips, that will trigger a menses. So if they haven't had their period return yet, that doesn't mean they're not fertile, because their fertility is going to start about 14 days prior to their first period, and we don't know when that will be. So now what does this look like if we are breastfeeding? So elevated prolactin levels prevent ovarian response to FSH. So without FSH, we don't have growing follicles that are making estrogen, and our estrogen levels will be low postpartum. The postpartum period is naturally low in estrogen, and that's worth considering when you think about wound healing for the vagina. If there was significant lacerations, or potentially if she's having pain with sex, sometimes having a little bit of topical estrogen can go a long way in helping to resolve those symptoms for postpartum women. So the duration of anovulation depends on frequency, duration, and proportion of supplemental feeds. So if she's not supplementing with formula or donor milk, if she's breastfeeding frequently, if she's breastfeeding for long periods of time, all those factors will keep her from ovulating sooner. So then if she's exclusively breastfeeding, the risk of ovulation is 1 to 5% if the following elements are met. And 1 to 5% is actually better than the pill when you think about contraception. Nursing or pumping at least every 5 hours. So if baby's sleeping through the night, then that protection is going to wane. The infant is only being fed mother's milk, so we don't have supplementation. Menses hasn't returned yet, and it's within that first 6-month period postpartum. So within those first 6 months, if she's not going more than 5 hours, she's not supplementing, and she hasn't seen her period, she's got really good birth control. That's commonly referred to as lactational amenorrhea as far as family planning options go. Particularly if you're working in low-resource settings, this is a really cheap form of birth control. Certainly not cheap in terms of a woman's time and effort, but purely based on cost. And it can be empowering that she has so much control over it. It's high effectiveness. And if she takes it seriously, she can really use this as a good form of birth control for a while, like going out of her way to make sure she's waking up to nurse baby or pump. So definitely something to consider. So whether it's due to resources or perhaps religious beliefs, this can be a really effective form of birth control, and she can take it seriously, going out of her way to make sure she's waking up to either nurse baby or pump making sure she's not supplementing unless it's needed, that sort of thing. She can use this strictly as a form of birth control. It can be really empowering for women to be able to provide them with the parameters for what helps make it especially effective. Okay, let's talk about the vagina and perineum. So it heals so well, and that's because of estrogen. So even though estrogen is lower in the postpartum period, the vagina has a pretty good source of it in general compared with the rest of the body. So even by 3 weeks postpartum, you'll be able to see vaginal rugae begin to return. So her vagina is all stretched out from the birth, and then it starts to accordion back up again. You might know Hymen tag. So basically there was a firm or fibrous ring there, a little past the introitus, and now what might remain after the birth would be little tags. Another word for that is myrtiform caruncles. Typically they're not an issue, but it can bother some women. Like I've had a few women reporting pain with sex related to them. Like it kind of tugs at it a little bit differently and is uncomfortable. If there isn't a lot of blood flow to it, or if it has a really thin base, you could even just tie it off with some sterile string. Or I've even used like the Alice clamp, where I've just clamped down, kept it there for a minute, and then taken it off, and then you can cut it. So you can use a string or a clamp and then just cut it off. But I would just do that if it's bothersome, if it's causing pain or discomfort. Vaginal muscles will gradually regain tone for the first 6 to 8 weeks postpartum, and they may need a little bit of help. So if they're coming in for their 6 to 8 week postpartum check and we're not all the way back yet, I think referring people to pelvic floor PT can be really empowering. The majority of European countries, that's just a standard part of postpartum care for all women. And to just know where your body's at with healing and to be able to help promote its healing and its strength can be really empowering. So I would strongly encourage all of you to consider doing that with your postpartum women, and think about, finding the contacts in your community. Where can I send people? Be aware of where your contacts are and connections are within your community. It's worth noting that even if a woman didn't have a laceration that needed repair or didn't even have any big lacerations to even chart, perineal pain can continue up to 3 months. So that's one area where I don't necessarily expect us to be all the way back to normal at 6 weeks, and that's okay. So even if there's no apparent trauma, just recognizing that perineal pain can take longer than 6 to 8 weeks, and that can be normal. I've even heard 3 months. One study found that 3 months was the most common time for women to report feeling ready to have sex again. And so I tell women, a lot of people come into their 6 to 8 weeks thinking we'll just tell them they're good to go. But if they're not feeling great, if they're still feeling sore, then I just say wait. The best time to know that you're ready is that you're feeling ready and you're feeling good. Even so, I worked with one midwife who would tell moms, no matter how long you wait, the first 7 times aren't going to feel great. So to a certain extent, that is true. It's perfectly fine to wait longer. And I tell moms, if you need to just tell your partners that I said you're supposed to wait 3 months, then you just tell them that. That's fine. Like, I'm not concerned by what I'm seeing, but if you're not feeling great, just wait. But at the same time, if you've waited for a while and you tried and it wasn't feeling great, know that it can take a little bit of time to readjust for it to start to feel good again. But yes, encouraging them to give it more time to heal if they need it, soak in the tub, and care for themselves. I also find it interesting that all major world religions have postpartum sexual prohibitions, so it's built in to give them some extra time to heal, and I think that's great. And then weight loss, there's typically an immediate loss of about 10 to 13 pounds right after the birth. And then by 6 weeks, it's about 28% of women that are back to their pre-pregnancy weight. And the remainder, it's typically lost by around 6 months. I think it's worth noting this for women. It's not uncommon for women to come in at 6 weeks discouraged that they're not back to their pre-pregnant weight, and to just normalize that that's not most common. If they gained more in pregnancy, then they're more likely going to have a net gain after pregnancy. And lactation may help to facilitate weight and body fat loss. At its peak, it's often about 500 calories a day that women are losing in the form of breast milk. So that can be something to encourage people if they're frustrated that they can't be, as active as they want to be postpartum, or if they're wanting to focus on weight loss, to let them know that even when they're sitting on the couch with their baby, they're doing a little something. I also think there's space for us to just normalize that pre-pregnancy isn't always fully attainable. Like, our bodies are a new normal postpartum, and that's okay. So I think to kind of approach this topic sensitively and in a way that's empowering for mothers because their bodies have gone through tremendous change in order to give new life, and it's continuing to sustain their children, even in its postpartum form too. And that in the context of promoting good, healthy, nutritious foods, and that they're staying active, it's perfectly okay to be entering into a new season of how their body looks and feels, and to be supportive of them in that. Okay, moving on to thyroid function. So as you remember, the thyroid increased in volume by about 30% in pregnancy, and then that gradually regresses over 12 weeks. And then you'll recall that's not a nodular growth, it's diffuse. So our thyroid hormones increased during pregnancy, and then they'll go back to being normal levels by about 4 weeks postpartum. And it's important for us to recognize that there's an increased risk for transient autoimmune thyroiditis that can lead to hypothyroidism in the postpartum period. So Hashimoto's thyroiditis or autoimmune thyroiditis, the most common time it's diagnosed in women in the US is in the postpartum period. So that risk for thyroiditis really extends into that first year postpartum, and it can be kind of hard to find it in that a lot of the symptoms people would report with for hypothyroidism are common in the postpartum period. So feeling fatigued, you're staying up late with baby, hair loss, that's very common postpartum, mood fluctuations and changes, potentially challenges with losing weight. So all of those could be either. And I'm just thinking back to one mom I had not that long ago where she lost maybe 20 pounds in the first couple months postpartum. And that seemed appropriate just for her body size. And then she gained 40 pounds over the next 3 months. So really fast. And she was having all the other symptoms. Maybe the rest of it was difficult to tell, could this be your thyroid or could this be postpartum? But yes, she definitely had Hashimoto's. So I think I have a pretty low tolerance for checking if people are having symptoms postpartum that aren't explained by only having had 4 hours of sleep the night before. So have a low tolerance to check. Okay, glucose regulation. So insulin needs change dramatically after the birth of an infant. So like if somebody has gestational diabetes, that should resolve rapidly postpartum. So generally, they'll stop needing insulin immediately postpartum. And if it's not resolving rapidly, then it would be worth doing a more thorough follow-up because it could be that she had undiagnosed diabetes going into her pregnancy. Gestational diabetes should resolve quickly. Okay, cardiovascular system. So you'll remember that we had significant cardiovascular changes in pregnancy. Plasma volume decreases immediately postpartum. In pregnancy, she had a lot of plasma volume in her bloodstream, but then also in extravascular spaces. So her feet were swollen, her hands were swollen, etc. So in that immediate postpartum period, all of the fluid that was in extravascular spaces will move into her blood vessels, and then she can diurese it. So it's actually about a whole liter of fluid will shift from being from extracellular spaces into the intravascular space. From there, she can sweat it off, she can pee it off, but that really helps to give her a buffer. If she has lost a lot of blood, having that shift in fluid helps give her some hemodynamic stability postpartum. So that's a very common experience for postpartum women, that they're sleeping at night and they're just sweating and their sheets are wet, they're needing to pee a lot. Expect this shift. So for hemoglobin changes, erythropoiesis, or making more red blood cells, that's stimulated prior to the birth and then going into postpartum as well. So that's a wonderfully protective mechanism in anticipation of losing blood at birth. Hemoglobin can be potentially immediately impacted if she loses a lot of blood, and then it's all that plasma coming back into the bloodstream that can have a bit of a dilution effect that could potentially transiently make her hemoglobin lower as well. Interestingly enough, though, there tends to be a 5% increase in hematocrit with vaginal births versus there's about a 6% decrease in hematocrit with cesarean births. We do expect a higher blood loss with cesarean birth, so that's not unexpected. It does take a blood loss of about 1,000 milliliters to cause a hemodynamic change in a woman's body. Less than that, and she should essentially be unaffected. Generally, a postpartum hemorrhage isn't called unless it's been over 1,000 milliliters for cesarean births. And we used to use 500 milliliters as our cutoff for vaginal births, and some still do use that, and it's shifting to be 1,000 regardless of birth. So I think that's something to keep in mind from one institution to the next, especially if you're comparing rates. What is their cutoff? What are they using to officially call something a postpartum hemorrhage? It generally takes about 4 to 6 weeks for hemoglobin to return to pre-pregnancy levels. We expect that pulse and stroke volume will remain elevated for 30 to 60 minutes immediately following the birth, and then there's a transient rise in blood pressure just by about 5% for the first 4 days postpartum, so pretty minor. Pulse is going to be the first indicator that you've had significant blood loss. So just in terms of prioritizing, if I have a woman who I'm concerned might be heading towards a hemorrhage, that's the first thing I'm going to want to know is what her pulse is. Cardiac remodeling from pregnancy can result in an increased cardiac output for even up to a year in healthy women. So good, strong cardiac output. For most women, it's about 6 to 12 weeks postpartum that it returns to normal. The greatest level of coagulability is going to be within that first 48 hours postpartum. And that's so important because you've got about 0.5 liter a minute of blood flowing to the placenta. So it's really important that that coagulability kicks in right away. So you've got the uterus clamping down to help clamp off those blood vessels that are running through the uterine walls. And then you've also got this increased ability to clot. And that's really important. That's the number one reason that women die worldwide around childbirth is because of a postpartum hemorrhage. On the other hand, it also puts women at an increased risk for blood clots. So that's a reason to get moving pretty early postpartum. So we certainly want her to rest, and we don't want her to be so active that her uterus has a hard time staying clamped. But it is important to be up and moving about pretty early, at least in small ways, to be able to get blood flowing and decrease our risk for clots. Okay, almost there. Last system, we're on the urinary tract and renal functions. So dilation of collecting systems returns to normal by 6 weeks. And you'll see 6 weeks coming up a lot here. So it makes sense that we are often seeing them postpartum between 6 and 8 weeks. We can see that everything's resolving well. Some may have a permanent dilation of the renal pelvis and urinary stasis, so be aware of that. There tends to be a slight decrease in bladder capacity at about 4 weeks. And prolonged labors and epidurals can diminish bladder function transiently, but it should return to normal. Glomerular filtration rates return to normal by around 8 weeks, and then the renal pelvis flow is depressed for up to a year. So women immediately postpartum are at an increased risk for UTI. Some of that is related to bladder and urethral trauma from the birth. Sometimes overdistension of the bladder during labor or postpartum, maybe a catheter is pulled too early, that sort of thing. Can also put women at an increased risk for UTI. I really like to encourage women to pee when I think the birth is going to be pretty soon, just because postpartum, sometimes it can be challenging. Like that first pee can be difficult in terms of just lining up sensations, or they might be nervous about doing it if it might cause some stinging. So I try to get people to the point where they have an empty bladder just before the birth. So the dysuria from perineal lacerations and incomplete emptying, all of those can be contributed to increasing her risk for UTI. And then I think it's also important to recognize that to have carried a baby for 9 months puts a lot of pressure on her pelvic muscles. And there's a little bit of shifting that has to happen to postpartum. It's kind of all her abdominal organs and pelvic organs sort of find their position and place again. So giving her some time to heal in that and encouraging her to be regularly going to the bathroom, and some of that shifting can make incomplete emptying be more of an issue. So again, pelvic floor PT can be great postpartum. So a few more honorable mentions for changes in the postpartum period. So the hair growth that was awesome in pregnancy is going to slow down in the postpartum period, and oftentimes that's seen as hair loss. You have a higher percentage of hair that's in the static fallout phase and a lower percentage of hair that's in the growth phase. There's a generalized transient decrease in bone mineralization, so lower calcium, especially if they're breastfeeding. But then once breastfeeding ends, there's a rebound and calcium levels tend to be even higher than prior. So just know that that's transient. Their abdominal wall remains soft, and return to normal is gradual and can be aided by exercise. Diastasis recti may remain, And my general threshold is at 6 weeks postpartum. If I still feel a 2-finger gap, I like to refer them on to pelvic floor PT. But either way, we can talk to them about exercises that can help. Usually, though, it can come together just fine without us having to put too much work into it. And then they might notice that their striae become a silvery color too. Okay, and then to just wrap up here, I wanted to just reflect on what it means to be taking care of postpartum women and families. So I really think that we drop them off too quickly. So much life transition is happening postpartum. Yes, a lot of it is physical, and so much of it is emotional and social too. How well can you prepare a new mom? With so much change happening in that immediate postpartum period, it can be hard for her to be super receptive to instruction. So I think a good piece of that preparation is preparation in the antepartum period. And then really being frequent about checking in. If it's going well, then great. But if it's not going well, it oftentimes takes us too long to figure it out. I think most commonly in the US, people will have a rounding postpartum before they leave the hospital, and then they might not see their provider again till 6 to 8 weeks postpartum. If something's going on, that's too long to wait. At one of the birth centers where I worked, we would send them home 4 to 6 hours after the birth, and then we would do 1 day and 3-day postpartum home visits, and then we would call them as a basic check-in at 1 week, and then they would come into the clinic at 2 and 6 weeks. So there are certainly different models for postpartum care in the US, but that's worth really exploring. And again, if it's going great, great. But if it's not, how are we making sure that we're going to be there and that we're able to pick it up quickly? So postpartum is a really big shift. The baby comes out, the placenta comes out. With that is a huge dip in hormones. If it's their first baby, their world is turned completely upside down. You add on to that hormonal shift a bottom that's healing, milk that's coming in, painful breasts, maybe discouragement with starting breastfeeding, trying to navigate how you want to parent with a spouse where maybe both of your instincts aren't lining up very well, sleepless nights with the baby. It really is a lot. And if it's their second baby, well, the life-altering piece might be more challenging with a first baby, adding on a second baby, trying to figure out how to work with their toddler as well as their baby. It's just a lot. So a lot going on there that's both wonderful as well as really hard. So it's a wide range of emotions. We invested a lot in being pregnant with those in our care in pregnancy. And then certainly during labor and birth, we made a point to be really present. What does it look like for us as midwives to be present with women and families in this postpartum period and transition? Okay, so I'm going to leave you with that, and I hope you all have a great week.